We welcome today Dr. Aditi Bedi ma'am, who has done her master's from Manipal University and has 5 years of clinical experience at Dinanath Mangeshkar Hospital, Pune. And she's currently working as assistant professor, CVRS department at D.S. Brijlal Jindal College of Physiotherapy. It's an honor to have you with us, ma'am. Handing over the session to you.
Thank you, Fareen, for such a warm welcome. It's always great to be associated with you all. Okay, so today we would be talking about oxygen transport dysfunction and its implication on physiotherapeutic treatment. So next slide, please. So we would be discussing about the definition and steps of oxygen transport, various factors that affect O2 transport, oxygen cascade, factors influencing alveolar oxygen tension, the dissociation curve, bioenergetics. Then we would be also talking about, next slide, please. We would be also talking about epoch, lactate threshold, oxygen transport dysfunction, the effect that pregnancy, obesity, or exercise can have on the O2 transport. We will be also discussing about few effects of various pathological conditions on O2 transport and implication of oxygen transport and its dysfunction on the PT techniques. Next slide. So oxygen transport, it refers to the delivery of fully oxygenated blood to the peripheral tissues, the cellular uptake of the oxygen, utilization of oxygen from the blood, and also return of partially desaturated blood to the lungs. So right from entry to exit, so all these steps come under oxygen transport. So now next slide, biological work requiring continuous oxygen supply are the cardiac muscles, smooth muscles, skeletal muscles, various cellular metabolic processes that take place, and also the nerve impulse transmission. So all these things require continuous oxygen supply. Next slide, please. So now we would be discussing about various steps in oxygen transport. So it starts right from the inspired oxygen and the FiO2 or the quality of the air that we breathe in. Then it reaches the airways, from there to the lungs and the chest wall. By the process of diffusion or perfusion, it will reach the bloodstream. Next slide. So depending on the myocardial function, the contractility, the peripheral circulation, it will then reach up to the tissues. Then tissues will be able to extract oxygen, and carbon dioxide would be transported back to lungs for the recovery. So these all things are the steps of our oxygen transport. So now let's talk about few factors that perturb oxygen transport or that can actually affect the oxygen transport. So these various stresses are exercise stress, gravitational stress. BMR is also one of the factor that determines O2 transport. So temperature and humidity, emotional stress, and state of arousal. So let's talk about exercise stress in a bit of detail. So exercise is the greatest perturbation to homeostasis and oxygen transport in humans. So our cardiac output can increase as high as 5 times to adjust to the metabolic demands of exercise stress. So all steps in oxygen transport pathway are affected by exercise stress. Okay, so the ventilation will increase initially. The ventilation perfusion matching will be optimized to maximize the oxygenation of the blood. So in an attempt to maintain up to the for the cardiac output and the oxygenation demands, the heart rate and the stroke volume both will increase. Thereby, cardiac output will increase, and oxygenated blood will be delivered to the tissues. At tissue level also, because of exercise or because of training, the extraction capacity of oxygen will be increased. Gravitational stress. So changes in the body position results in significant fluid shift instantaneously, and it also threatens the hemodynamic stability. So one example is patient who is bedridden for a very long period of time, and when we get him up in the upright position, so there is a shift of fluid and hemodynamic instability can occur. So that is all because of the effect of gravitational stress. So heart and peripheral vasculature will detect the changes and accommodate quickly. So this capacity is quickly lost with recumbency or deconditioning. That is why the transitions have to be slower, like from the supine position to sideline to bedside sitting, and then gradually up in the standing. So restoration of gravitational stress with upright position is the only means actually to reduce the orthostatic intolerance and its sequelae. So it is very, very necessary to move gradually from supine to side lying, and ensure that the patient is sitting in bedside sitting for good 15 to 20 minutes before you make the patient stand. This is especially true when we are making the patient stand for the first time after a prolonged bed rest. Now let's see few of the factors related to disease that can affect the oxygen transport. So it is fever, the disease process itself. So process of healing and recovery also will require more oxygen. So the demands will go up, and unless the supply is able to match up to the demands, there are chances of oxygen deficit. So the disease process of healing and recovery, thermoregulatory disturbances, reduced arousal, increased arousal from anxiety and pain. So reduced arousal will also affect O2 transport. Increased arousal because of pain or anxiety will also have its effects on oxygen transport. Sleep loss, medical and surgical interventions, fluid imbalance, and also the medication. So all these factors can affect the oxygen transport. Now let's discuss about oxygen cascade. So partial pressure of oxygen in the dry air is around 21.2 kilopascals or 159 mmHg, and then it further starts decreasing by the time it reaches the alveoli to the arterial blood to the capillary and then the venous blood. Okay, so it will start decreasing from the dry air till it reaches the cellular level. So at the mitochondrial level, it is only 3.8 to 22.5 mm Hg. So these steps by which the partial pressure of oxygen decreases from the air to the mitochondria is known as oxygen cascade. So any one step may be altered under pathological circumstances, and that might result in hypoxia. So next slide, please. So let's discuss about few factors that can influence the alveolar oxygen tension. Next slide, please. Okay, so we have dry barometric pressure, inspired O2 concentration, oxygen consumption, alveolar ventilation, cardiac output, and the Fink effect. Okay, so let's discuss what that is. So the first three factors are primarily or directly related, and the other two factors are indirectly related. So Fink effect is nothing but it is a phenomenon that occurs when a person's oxygen level drops. Okay, so after breathing in large amounts of nitrous oxide, but it can occur when the nitrous oxide anesthesia is stopped. Okay, so when the anesthesia is stopped, the gas will rapidly leave the blood and enter the alveoli, thus diluting the oxygen in the alveoli. Okay, so because there is dilution of oxygen in the alveoli, there is reduction in the partial pressure of oxygen, which can lead to hypoxemia. Okay, so that is the Fink effect, and this can be prevented by increasing the concentration of oxygen and administering 100% of oxygen for at least a few minutes before the procedure. That is why the patient is pre-oxygenated properly, so that the Fink effect can be reduced. Next slide, please. Next, coming to the alveolar arterial partial pressure of oxygen difference. Yeah, that is same side. Factors affecting the alveolar arterial partial pressure of oxygen difference are the V by Q mismatch. So factors that result in either increase in ventilation or decrease in ventilation or cause of shunting that might affect the alveolar arterial PO2 difference. So actual alveolar PO2, alveolar ventilation, temperature, pH, and base excess, the cardiac output, and also the hemoglobin concentration. So all these factors can directly or indirectly affect the alveolar arterial PO2 difference. So most of the cases, in case this difference increases, one of the solution is increasing the FiO2 of the oxygen that is delivered. Next, now let's discuss about how the oxygen is carried in blood. So it is carried in two forms, either in the form of physical solution, so plasma and ICF, or it can be bound to the hemoglobin. So physical solution in plasma is in the intracellular fluid, and a reversible chemical combination is with the hemoglobin. Next. So it is carried in physical solution in both RBCs and plasma. So amount which is carried in normal blood in solution at 37 degrees Celsius is around 0.003 ml per dl mmHg, and amount of O2 in physical solution, it rises with decreasing temperature for the same PO2. Next, so this was in case of physical solution. Next is in terms of association with the hemoglobin. So one hemoglobin molecule consists of four protein chains, each of which carries a heme group. Okay, so it has two alpha chains and two beta chains, and oxygen carrying capacity of hemoglobin is around 1.34 ml per grams. So now any abnormal forms of hemoglobin like sickle cell anemia or thalassemia is going to affect the oxygen carrying capacity of the blood, that is oxygen carrying capacity of the hemoglobin, and thereby can result into hypoxemia or hypoxia. Okay, now let's discuss about O2 hemoglobin dissociation curve. So we all know that it is a sigmoid shaped curve. The upper part determines the acceptance of O2 by hemoglobin, and it depends on the partial pressure of oxygen, and the lower part determines the dissociation. There is a point called as P50. We will discuss it shortly. P50, at which the PO2 or the partial pressure of oxygen is around 25 to 27 mmHg, and when the curve shifts to the left, that indicates association or acceptance of oxygen by hemoglobin, and shift to the right indicates dissociation of oxygen from the hemoglobin. Next slide, please. So in very simple terms, hemoglobin oxygen dissociation curve is a curve that plots the proportion of hemoglobin in its saturated form. Okay, so that is the vertical axis against the partial pressure of oxygen. So that is around the x-axis. So this curve is important tool for understanding how our blood actually carries and releases oxygen. So the shape of the curve is shape of the curve results from interaction of the bound oxygen molecules with the incoming molecules. Okay, so we can see in the curve also it is a sigmoid shaped curve. So the binding of first molecules is difficult, but as hemoglobin's affinity for oxygen increases, successive molecules of oxygen go on binding. So the initial binding is a bit of difficult. That is why the curve goes up slowly. But once it is in form, then it goes up quickly, or it reaches the plateau. So as this limit is approached, very little additional binding sites binding occurs, and the curve levels out as the hemoglobin becomes saturated with oxygen. Okay, so hence the curve has a sigmoidal or an S shape. So at pressures above around say 60 mmHg, the standard dissociation curve, if you can see, it is a relatively flat curve. Okay, so which means that oxygen content of the blood does not change significantly even with large increase in the oxygen partial pressure. So initially, if you see the curve, even slight increase in the partial pressure of oxygen is increasing the saturation. But once it reaches a plateau, not much change in PO2 will bring about a change in the oxygen saturation. So the partial pressure of oxygen in the blood at which the hemoglobin is around 50% saturated typically is about that as we just discussed is about 26.6 mmHg for a healthy person of course, and this is called as P50. Okay, so P50, it is a conventional measure of hemoglobin affinity for oxygen. So in the presence of disease or other conditions that change the hemoglobin oxygen affinity, basically we can see that the shift of curve will occur either to the left or the right. Okay, and P50 will change accordingly. So in normal healthy individuals, P50 is around 26 mmHg, but depending on the disease process and the curve, if it is shifting to the left or to the right, the P50 value will also change. So an increased P50 indicates a right upward shift of the standard curve, which means that larger partial pressure is necessary to maintain 50% of the oxygen saturation. And this also indicates, as we discussed, to shift to the right will indicate decreased affinity. Conversely, when the P50 is on the lower side, it will indicate a leftward shift and a higher affinity of hemoglobin and oxygen. So P50 is important in normal healthy adults. The P50 point is at around 26.6 mmHg of partial pressure of oxygen. Next, now let's discuss few factors that can shift the curve to the right and or shift the curve to the left. So when the partial pressure of oxygen decreases or when the pH decreases, the curve is shifted to the right, or there is increase in PCO2 or H plus ion concentration, or when the body temperature goes up, for example, fever, or the 2,3-DPG proportion increases, that is when the curve is shifted to the right. Okay, so the shift of curve to the left is seen in case of fetal blood, or when the H plus ion concentration decreases, or when the pH increases, that is more towards the alkaline side. So this was all about the hemoglobin dissociation curve. Next slide. So let's discuss about the energy sources now. So foods are primarily composed of carbon, hydrogen and oxygen, and in case of protein there is also nitrogen. Energy is stored in the form of ATP. So there are three basic energy systems. Next slide. There are three basic energy systems. So that is the ATP PCR system, the glycolytic system, and the oxidative system. So the first two systems are anaerobic system, and the oxidative system is the aerobic system. Let us discuss about these systems in brief. So first is the ATP PCR system. So ATP and PCR are stored in the muscle cells. So PCR, we all know it is the fuel source, and this process does not require oxygen. So ATP PC is replenished during the rest. So it provides energy for short, quick bursts of activity. Okay, so the capacity is small and the power is great. Okay, so short duration activities which require high intensity, that is when the ATP PCR system comes into picture. So it is a major energy source during the first 30 seconds of intense exercise. Because it is anaerobic, it will not be able to sustain for a long time, but it will yield high power. Okay, so it is the main source of main source of energy during the first 30 seconds of intense exercise. Next slide. Next is the anaerobic glycolytic system. So here glycogen is the fuel source. Okay, in ATP PCR, PCR was the fuel source. Here glycogen is the fuel source. Again, this is an anaerobic system, so no oxygen is required. ATP is resynthesized. Lactic acid is produced because of metabolization by this system, and it provides energy for activity of moderate intensity and short duration. Okay, so ATP PCR contributed to short duration activity but high intensity. Anaerobic glycolytic system will contribute towards short duration activity but with moderate intensity. So it is a main source of energy from 30th second to 90th second of exercise. Okay, so the first 20 to 30 seconds it is ATP PCR, and then from 30th second onwards till 90th second or so, like 1 minute or so, 1.5 minute or so, it is more of anaerobic glycolysis system. So here again, the maximum capacity is intermediate and the maximum power generated because of this system is also intermediate. Next slide. Third is the aerobic system. So here the fuel source can be glycogen, or it can be fats, or it can be protein. So basically all three, either carbohydrates or fats or proteins. So it is utilized as per availability and the intensity of exercise. This system, because it is an oxidative system, will require oxygen. So ATP is resynthesized in the mitochondria of the muscle cells. So the oxidative, the glycolytic system was more in the sarcoplasm, whereas aerobic system takes place in the mitochondria. So maximum capacity is again great, maximum power is small. Okay, so the power is highest in case of ATP PCR system, but the capacity to sustain that activity is more in the aerobic system. So this system predominates over the other energy systems after the second minute of exercise. Okay, so we just saw ATP PCR is initially 20-30 seconds of activity. From 30th second of activity till around 90th second of activity, it is the glycolytic system, and 90th second onwards or 2 minutes onwards, it is more of the aerobic system that comes into picture. Next slide. So oxidative system, it is the complex of all energy systems. It has tremendous energy yielding capacity, and it is a primary method of energy production during endurance events, wherein you have to sustain that activity for a very long period of time, and intensity is towards the moderate side. So it can have oxidation of carbohydrates, or oxidation of proteins, or oxidation of fats. Okay, so the important point to remember is all these three energy systems do not work independently. All the three systems will contribute. Only difference is one system will predominate over the other remaining forms of systems. Okay, so depending on the duration of the exercise, depending on the mode of the exercise, energy systems or the interplay between these systems will change. Okay, so initial 10 seconds to 100 meters of sprint, it will be more of ATP PCR. Okay, then it will be anaerobic glycolytic, and then it will be oxidative. When you have a longer duration activity, say for 30 minutes or 1000 meters of run, it is going to be more of oxidative. But again, it will start with ATP PCR, then anaerobic glycolysis, and then oxidative. So it does not mean that one system will act independently or exclusively. It is going to be a combination of all the three systems. Just the difference is one system might predominate over the other, depending on the duration and the intensity of the activity. So oxidative capacity of muscles also depends on the enzyme activity, the fiber type composition. We all know type 1 fibers and type 2 fibers. So depending on the fiber recruitment or the fiber composition, the oxidative capacity will vary, and also the oxygen needs. So the oxygen needs, the duration and the intensity of activity will dictate the oxygen needs. Now let's talk about the maximal capacity of aerobic exercises. So the gold standard that is used to measure the maximal capacity of aerobic exercise is VO2 max. So maximal limit of increasing VO2 is VO2 max, or it is also called as the maximal oxygen uptake, and it is the best single measurement of cardiorespiratory endurance and aerobic fitness. Next slide. So this was about aerobic. So VO2 max is the gold standard. When we talk about maximal capacity for anaerobic exercises, these are the few terms that become important. So one is oxygen deficit and one is EPOC. Okay, let's discuss one by one. So when we start exercising, the oxygen supply is not going to start immediately. Or in other words, as we start exercising, the energy demands are going to increase, or the oxygen demands are going to increase. But it does not happen that the oxygen is supplied immediately or all the systems come into picture immediately. Okay. So the initial time frame, just go back to that graph, please. Back. There is a, yeah, this graph, yes. So the initial time period when the activity has increased, but oxygen is no longer, or oxygen has not yet been delivered to that, to meet up to that activity limit, that is when the oxygen deficit occurs. Okay. So then the oxygenation or the delivery of oxygen will start properly. It will try and meet up to the energy demands. And then that is called as oxygen deficit. Okay. So the initial portion is called as oxygen deficit. Then when we are doing that activity, the oxygen supply is able to meet up to, I mean, the oxygen supply is able to meet up to the demand of that activity. When we stop doing exercise, again, it does not happen that the oxygen levels will go down immediately or the supply will be cut off immediately. Okay. So there is going to be a gradual decrease in the oxygenation process, and that is called as excess post-exercise oxygen consumption. Okay. So when we stop exercise, it does not mean that the oxygen demands have disappeared. We still need oxygenation, and that is why we see a gradual dip in the oxygenation process. So that is called as excess post-exercise oxygen consumption. Now there are two parts to it. First is the fast one, first is the fast one, and the second part is the slow epoch. Okay, so first is fast epoch and second is the slow epoch. So fast epoch occurs in order to resupply or re-establish all the deprived ATP resources that have been used up during the exercise, and the slow epoch that occurs to clear the accumulated lactate. Okay, so that is a significance of slow epoch and fast epoch. Yes, next slide, please. So lactate threshold during exercise of increasing intensity, when the rate of lactate production exceeds the rate of lactate clearance or removal, that is when the lactate starts to accumulate, and that is called as lactate threshold. So it is a point at which blood lactate appears to increase above the resting level, and it reflects the interaction of the aerobic and the anaerobic energy systems. So that is why lactate threshold is an important terminology to determine the anaerobic capacity. So it represents next slide. So it represents significant shift towards the anaerobic glycolysis that forms lactate. Okay, so that is also called as anaerobic threshold. It is also called as onset of blood lactate accumulation or OBLA. And lactate accumulation is one of the reason that contributes to fatigue. Okay, so because the initial part, because oxygen levels are not able to meet up to the demands, you have more of anaerobic system, so that is taking care of the oxygen deficit, and then the activity goes on when the oxygen demands can meet up the supply, and the supply meets up the demands, and then when the activity stops, oxygen demands do not drop immediately. It will have a slow slow decrease in the oxygen levels, and that is called as epoch. So interaction of variable factors governing oxygen delivery. So cardiac output has a role in it, and that is multiplied by arterial oxygen saturation into hemoglobin into 1.31 plus 0.3. So that is the equation that gives oxygen delivery. Next slide. Now let us discuss about anoxia. So anoxia is basically when the body or brain completely loses its oxygen supply, and it is usually a result of hypoxia. And most common term that is used is hypoxic anoxic injury. Okay, so hypoxia is decreased and anoxia is as good as absent. So stagnant hypoxia. So when the blood is blocked from reaching the brain or other parts of the body, and that is called as stagnant anoxia. Stagnant anoxia. So this can occur with the stroke or heart attacks. Okay, so when the blood volume in itself is not reaching, that is why it is called as stagnant anoxia. So anoxia occurs when there is not enough oxygen in the blood, there is not enough oxygen in the air that you breathe in, and this can again occur at high altitude, okay, or during suffocation. So that is anoxic anoxia. The third terminology is anemic anoxia. So anemic anoxia is when there is not enough hemoglobin in the blood. Okay, so we have seen that hemoglobin is the carrier of oxygen. So when there is not enough hemoglobin in the blood, that is when the blood is not that capable of delivering oxygen to the body's organs. So that is called as anemic anoxia. There is also one more form called as toxic anoxia, when chemicals like say carbon monoxide or cyanide or alcohol, it prevents blood from carrying oxygen. That is called as toxic anoxia. So these are some forms of anoxia. So hypoxia, it refers to the lack of oxygen in particular compartment. So it could be either alveolar or it could be tissue hypoxia. So tissue hypoxia basically results from four main causes. As we discussed for anoxia, more or less the same ones. So it is hypoxemic, anemic, stagnant, and histotoxic. Next slide. So hypoxemic hypoxia or hypoxic hypoxia, it is present when the oxygen content in the blood is low. Okay, so most common reason is the altitude, wherein you have decreased partial pressure of oxygen. So diseases such as emphysema again, which impairs the efficiency of gas exchange in the lungs. So the oxygen content in itself is less when we talk about hypoxemic hypoxia. Next is anemic hypoxia. So it results from a reduced level of next slide please. So it results from a reduced level of hemoglobin which is available for oxygen transport. So although the patient may not be hypoxemic, the reduced oxygen content of the blood can result into tissue hypoxia eventually. Okay, so example of that is also carbon monoxide poisoning or anemia because of many different reasons. Next is stagnant hypoxemia. So hypoxia, so it is a low level of oxygen in the tissues due to inadequate blood flow. So we also saw stagnant anoxia, right? So the causes are same, wherein there is a state of low cardiac output because of any reason. So because the cardiac output is low, there is stagnancy, and that is resulting into hypoxia. Next. Next is histotoxic hypoxia. So it is an inability of the tissues to use oxygen, and that is because of interruption of the normal cellular metabolism. For example, mitochondrial dysfunction, it may lead to decreased oxygen utilization in sepsis despite adequate oxygen delivery. So even if you give excess of oxygen, the body is not able to utilize oxygen because there is mitochondrial dysfunction. Okay, so this has also been termed as cytopathic dysoxia. Next, so this was all about hypoxemia. So there are also terms called as hyperoxia or hyperoxemia. So hyperoxia, it refers to high oxygen content at tissue level, and hyperoxemia refers to high oxygen tension in the blood. Next slide. So let us look at few physiological effects of acute hypoxia and hyperoxia. So in case of hypoxia, the effects that can be seen is increased ventilation. There is pulmonary vasoconstriction, coronary vasodilation, decreased systemic vascular resistance, which is transient. There is increased cardiac output, and there is tachycardia to meet up to the body demands. In at the metabolic level, there is increase in 2,3-DPG. There is increased carbon dioxide carriage, that is called as the Halden effect. and there is increased cerebral blood flow due to vasodilation, again to counteract for the decreased oxygen content. And at the renal system level, the renin-angiotensin axis activation occurs, and there is increased erythropoietin production. So because of hypoxia, again, the patient is at risk of developing pulmonary hypertension, myocardial ischemia or infarction, hypotension, arrhythmias, lactoacidosis. Neurological level, when the body is deprived of oxygen, there could be a state of confusion, delirium, worst case is coma, or in case of when we talk about renal system, it can result into acute tubular necrosis causing acute kidney failure. Next is hyperoxia. So hyperoxia, there will be decreased ventilation, decreased 2,3 dpg, there will be decreased CO2 carriage, again the Haldane effect, and there will be decreased cerebral blood flow. So the associated risks are there is worsened ventilation perfusion matching, there could be absorption atelectasis, there could be myocardial ischemia again, or there could be reduced cardiac output, reduced coronary blood flow resulting into ischemia, increased blood pressure, increased peripheral resistance, increased reactive oxygen species, and there could be reduced renal blood flow, which can again result into kidney injury. So hypoxia or hyperoxia, either extremes of the parabola, are not going to be beneficial. Next. Now let's discuss about causes of hypoxia. So there is lack of oxygen in a particular compartment. For example, the alveolar level or the tissue hypoxia. There is hypoxemia, there is reduced cardiac output. The oxygen carrying capacity of blood is also low. So all those four types of hypoxia that we saw, any reason that or any etiology that can result into those four states can ultimately result into hypoxemia. So reduced blood flow because of hemorrhage or PVD, disrupted blood flow because of multisystem failure, or reduced ability of the tissues to extract oxygen, as in cases of septic shock, can also result into hypoxia. Next slide. Causes of hypoxemia. So hypoxemia is again partial pressures of oxygen. So when the PO2 or PaO2 is less than 60 mmHg, that is when the hypoxemia sets in, or the corresponding saturation for that is around 90%. Okay, so we have seen the oxygen hemoglobin dissociation curve. So saturation of 90% corresponds to somewhere around 60 mmHg of the PO2 value. So either it could be because of shunting or because of dead space. Both these things can cause hypoxemia. Next slide. So let's look at a few signs and symptoms of hypoxemia. So when the severity level is around mild to moderate, we can have confusion and agitation for CNS symptoms. There is tachycardia to meet up to the demands. Hypertension can be seen. Dyspnea can be seen, tachypnea can be seen. The breathing will become shallow and labored. The ABG report, mostly it will show PaO2 between 60 to 80 mmHg. Okay, so the hypoxemia will be mild. Beyond 60 is when it becomes severe. Okay, when it decreases further down to around 40, that is when it becomes severe. So the skin will appear cool and clammy in case of mild to moderate hypoxemia, whereas in case of severe, it will turn cyanosed. The PaO2 will be less than 60 mmHg. The dyspnea and tachypnea will worsen, and there could also be possible bradypnea or agonal gasping, or agonal respiration or agonal gasping can be seen. Cardiac level, there is always initial tachycardia, but ultimately if the hypoxemia further deteriorates, it will result into bradycardia and hypotension. Okay, so initially when the heart tries to pump harder and meet up to the demands, there is tachycardia and hypertension that is seen, and when it fails to do so, that is when the bradycardia sets in and the hypotension sets in. So CNS wise, again, severe cases, you will see lethargy or altered mental status can be seen. Next. So this was all about hypoxemia.